So there is a lot of discussion around menopause now on social media, on YouTube, and hopefully in a lot of doctors' offices. And that's awesome. But I still get really surprised when I see some quote unquote experts in the space that are spouting some really surprising recommendations. And what I really find interesting is where we see somebody who is proudly a feminist and they're a talking head around menopause, but they're continuing to spread some of the misogynistic, let's call them partial truths, or the gaslighting in the medical industry from the previous era. It's such an interesting contrast. And I find it fascinating that other women don't call them out on this. But let me just give you my perspective here. My practice is very unique. I work with a lot of postmenopausal women. And I work very specifically with patients with osteoporosis and sarcopenia. So they've lost bone, they've lost muscle. My interest is really in health span and longevity, but we created a program that reverses osteoporosis naturally. So I'm in a unique position to see a lot of postmenopausal women with osteoporosis, and I see the commonalities of most of their cases. And what I want to give to you today are my 3 tips for postmenopausal women, including perimenopausal women, but perimenopausal and postmenopausal women to protect their bone health as they go through menopause. All right. So hear me out. Top 3 shouldn't take too long. All right. Number 1 tip is watch what you eat. And I'm going to call this inputs. But I don't mean this like the way that you've probably been thinking about it for a lot of your life. So many women in this generation had concerns around body image issues for decades. And this is still true with women in younger generations today too. But this particular generation saw some really crazy fads. And a lot of these fads were really designed just to help women to get super skinny. That was the aesthetic that a lot of women were going for. Now, I looked this up actually because I was born in the 70s. And so I sort of missed some of this. So I looked up some common fads from the 70s. And there were things like the grapefruit diet, the cabbage soup diet. But then I saw some really bonkers stuff. So the tapeworm diet. Anybody ever do the tapeworm diet? That sounds like a terrible idea. Please don't do that. The cotton ball diet. I actually had heard of this. Eating cotton balls so it fills up your stomach so that you're not hungry. Definitely wouldn't recommend doing that. And then a lot of just restrictive diets in general. And that was sort of like the mainstay of how a lot of women ate because they wanted to stay lean above all else, or at least that's what they thought. What's the impact of that? Well, the impact of that is that they are now lean, they're frail, and their guts don't work very well. That all leads to osteoporosis. So what do we do with this population? Well, we help them to understand that you have to eat a diet that supports muscle maintenance and development. And that doesn't mean you need to get fat. It means we need to have a different mindset around body image that is more directed at composition and strength rather than simply being lean. And we see that in the menopause community right now. There's a lot of voices out here saying, hey, let's get strong. Let's lift weights. We're going to talk more about that stuff later. But how do we help people do that? It's very individualized. In general, though, we're going to recommend a protein-forward diet around 1 gram per pound of ideal body weight. A lot of women in this category, even though they are lean, still need to be a little bit carb restricted compared to the standard American diet. Some of them are eating a high carbohydrate diet because they're eating a low fat diet. That's another thing that needs to go by the wayside. But depending on their metabolic health and their starting point, carbohydrate restriction might be a part of this, although not necessarily. And I'm not talking about ketosis. I don't think that's actually a particularly good long-term plan for most women. So we want to make sure that women are getting healthy oils. So we're talking about either monounsaturated fats or even saturated fat, depending on someone's genetics, if we happen to know that. What I want people to avoid is a preponderance of omega-6 high, rich, polyunsaturated fats. So those are going to be like your vegetable oils or the seed oils, as they're commonly called on social media. I'm not saying that these things are the root cause of all evil, like some people are, but I do think that they do become rancid quickly. They are relatively new to our bodies, if you think about them from an ancestral perspective. And we know that monounsaturated fats like avocado oil and olive oil are going to be much better tolerated and lead to better blood profiles in the short term. Saturated fat was a very common fat source that was used by our ancestors. It's arguable today whether or not saturated fat is great for everyone. Is it good for some of the population? Is it dangerous for some genetic profiles? The answer is maybe. We really don't know. But my bias is monounsaturated fats, and saturated fat is the primary source of fatty acids in our diet. Now, the cool thing is we can label this whatever we want. This can be a Mediterranean diet. This can be a paleo diet. This can be a whatever diet. I don't want to put my name on a diet, but we have to understand that it is a protein forward, carbohydrate smart diet that could be carbohydrate restricted, but not low carb by any means, but an appropriate carbohydrate diet with adequate saturated fat, adequate monounsaturated fats, avoiding to some extent, if not completely, or to the extent possible, polyunsaturated fats as seed oils and vegetable oils, and then getting adequate calories. You have to get adequate nutrients. The best way to go about this is to track, make sure you're getting adequate micro and macronutrients. And if you're not, then definitely asking for help. All right, tip number 2. If we talked about number 1 being inputs, number 2 is outputs. So activity is critical. It gets more critical as we age. Historically, a lot of women in the osteoporosis world did nothing, or they did a lot of chronic cardio. They did, running, they did jazzercise, they did whatever was popular in their social group at the time. And the problem is none of those things help you to learn how to do resistance training, help you to lift heavy things that doesn't protect your muscle, and ultimately can lead to sarcopenia and osteoporosis. So what do we have our patients doing now? Well, now, more than ever, we need to do resistance training. We need to lift as heavy a things as possible without hurting ourselves. We also need to consider doing some high intensity interval training. I'll talk about the difference there. And I also like zone 2 training. So there's a lot of potential training to be done here. But notice I didn't say anything about yoga. I didn't say anything about Pilates. I didn't say anything about Legree. Not that I don't like those things. They have a lot of value. But we have to do these things first, and then we can add those things second. All right, so let's double click on resistance training first. So again, a lot of people in this population have never done resistance training, and that's okay. If you're going to work with somebody to help you to do resistance training, i.e. lifting weights, you got to ask for help. Please don't go out and try to do, a barbell back squat or a deadlift with a barbell if you've never done it before. You will likely hurt yourself. So this has to be somebody probably in person if you're somebody who's never trained. If you've trained and you kind of know what you're doing and you're just not doing it, then let's get going, right? There's so many different programs out there. We're building one ourselves. We have one for our patients, but there's a lot of different ways to do this. But the key here is you just got to do it. Muscle mass is so important, and it probably takes less than you think, especially if you're not particularly trained to begin with. The benefits of muscle mass are metabolic health, body composition, strength, maintenance of independence, cognitive function, mental health, better sleep, on and on and on and on. Muscle mass is king when it comes to longevity and HealthSpan. So you might be saying, well, what do I specifically do? Well, I can't tell you specifically what to do, but it could look something like body weight exercises. It could look like a 5-pound dumbbell out of the gate. It doesn't need to be complex. It just needs to be consistent, and we have to progressively overload, meaning that it gets harder and harder every day, or at least a little bit over time. Now, the goal is going to be about 3 days a week, but if we're going to do 3 days a week, it's got to be pretty high intensity. Now, I mentioned high intensity interval training earlier. That's not what I'm talking about. I'm talking about high intensity resistance training. All right. Now, there's some studies out there by Dr. Belinda Beck called the Liftmore studies. These are very specific in the bone health space. What she showed is that untrained individuals can do high intensity, meaning 85% of 1 rep max, safely and improve bone over time. So high intensity resistance training. Now, this is important because she also did impact training. So they call this intervention HIRIT, HIRIT, high intensity resistance and impact training. So we'll talk about impact training in other videos for bone health, but from a longevity perspective, we really need to focus on doing resistance training. Now, what about high intensity interval training or HIIT training, which I mentioned briefly earlier? Now, HIIT training is really important because if you just do resistance training, you lose eventually your cardiorespiratory fitness. So while we don't necessarily need to train to be a triathlete, we should have some capacity for your heart rate to go up and come down. That takes more than just doing resistance training. So high intensity interval training will drive your heart rate through the roof. Now, definitely understand your starting point here. Not everybody's heart can tolerate that. So understand where you're starting from, what high intensity means for you, and probably, again, ask for help here because high intensity interval training can be absolutely intimidating and it could potentially be dangerous. But this is different than chronic cardio. When I say chronic cardio, I mean going for a run. I mean doing a class like F45 or Orange Theory, where your heart rate goes up and it stays up. And those group classes, they actually have you wear a heart rate monitor and you can watch it on a screen and you'll see people's heart rate go up to 160, 170, and it stays there for 45 minutes. That's an aerobic workout. It's not a bad workout. It's just not interval training. And a lot of people look at those exercises and say, well, it is intervals, but you don't have enough rest. The intensity has to be high and it has to have an interval of workout, and then it has to have an interval of rest. Some people will do 20 seconds of intensity and then a minute of rest, but that could even be 2 minutes. It could be 3 minutes, depending on how hard and how long the intense part is. There's a lot of ways to split that up, but your heart rate has to go up, it has to come back down. And that's a key part. It has to come back down in between so that you are quote unquote resting, doesn't feel like rest, and then you go again. These workouts can be short, but they can be intense, and they definitely may not be tolerated. So please be careful with this, but understand that if you do want to push yourself as hard as possible for as long as possible, have the best health span, high intensity interval training is an important part of that. Now, high intensity interval training may be important, but it doesn't take up a lot of time, and you don't really probably need to do it more than once a week if you're just training for health span longevity, not for a specific athletic endeavor. So then what are you going to do from a quote unquote cardiovascular perspective for the rest of the time? Well, I like to do what's called zone 2 cardio. Now, zone 2 cardio is something that you can do with friends. You can do it while walking. You just have to keep your heart rate high enough that you're somewhere 65, 70% of your max. That's going to be a zone where you can have a conversation, but it's not easy to have a conversation. And this gets lower as we get older. Max heart rate is technically, if you want to be accurate, not that easy to measure, but you can use the 220 minus age for a simple, not particularly accurate heart rate. And then you can figure out what it looks like for you. And this could be walking. Again, this could be walking hills. This could be on a Peloton bike. It's probably not running. So I used to run. I don't run anymore. But when I would go from walking to running, my heart rate would go from sort of 120 to like 160. I can't run and be in zone 2. And I think that's probably true for most runners unless they're very efficient. So maybe a true runner, a marathon runner, maybe they can be in zone 2, but I don't know that that's true. Never seen those data. So anyway, zone 2 is going to be helpful to fill the time that you need to fill on other days where you're doing quote unquote cardio work. What we don't want to do is drive your heart rate up into the higher levels. That's where you want to do intervals, not chronic cardio. And this is why chronic cardio is so destructive, because chronic cardio in the 150s, 160s becomes inflammatory, has a much different response with cortisol and with the body. And this is why a lot of people don't tolerate, going on a 5-mile run or a 3-mile run. They don't do that well because the body doesn't respond well. Some people do great, that's fine, but it's not for everyone. Okay, so we hit high intensity interval training, high intensity resistance, and potentially impact training for bone. And then we talked about zone 2, which we're going to do on the other days that we're going to do cardio. And that could be, some people would say every day. I don't have time to train for 2.5 hours every day. If I did, I would do 45 minutes of zone 2 every day. But in my world, I do it maybe once or twice a week if I'm lucky. Again, I try to do it outside. I try to be walking. I try to do it with other individuals. So that's zone 2 cardio. All right. But what about other things? I haven't mentioned Pilates. I haven't mentioned yoga. I haven't mentioned Legree. I think there's value in all of these things. I think there's also a value in things like martial arts. I take Taekwondo with my oldest, and there is a black belt in there who started in her 70s. She's still in her 70s, and she went all the way through the ranks in her 70s and is now a black belt. She's phenomenal. I think that's amazing. But all those things are secondary. I want you to major in the major things. Don't worry about the minor things, even though they might seem important to you based on your social circles. Let's major in the major things: resistance training, and then beyond that, high intensity interval training, and potentially zone 2 cardio. Now, the third thing is what I call the inner workings. So there's a whole lot of potential things here, but I'm going to focus right on the hormone replacement therapy part because I talk about this a lot. It's very controversial, and people will call it hormone replacement therapy, menopausal hormone therapy. I'm talking about estrogen, progesterone, testosterone. When I talk to my patients, women tell me that they are really torn between this idea of aging naturally, because menopause is natural, losing hormones is natural, versus considering hormone replacement therapy. And then when they get into the conversation, they get scared because of the potential risks, and that natural state of menopause seems very appealing, even if it's really uncomfortable for some women. But this is what I see for women who are quote unquote naturally going through menopause. It's totally natural, and I totally get that. However, there are some very expected changes that are going to occur as a woman goes through menopause that can be impacted by hormone replacement therapy. Some of those things are loss of muscle mass, loss of bone, loss of skin integrity, changes in the bowel, changes in the bladder and the lower urinary tract, changes in your brain, changes in your heart. All these things are totally natural, but not things that I want for the women in my life and not things that I want for most of my patients. So we can have an impact on that with hormone replacement therapy if somebody meets the criteria to consider it. But for us, more women are going to meet that criteria than not, especially if they have, in my practice, a diagnosis of osteoporosis, because that's going to shift that decision-making equation a little bit. Now, when it comes to looking at hormones through the lens of HealthSpan, let's just talk about each of the hormones. So estrogen works on both sides of the equation for bone health. It can clearly help with the symptoms of menopause. It can help with vascular health, with heart health, with brain health. Yes, it's controversial, but there's so many issues with the research, and I have some additional videos on that topic. There are numerous protocols, synthetic progestins, that are all wrapped into the research, and it is really hard to make sense of what you see in the literature. So talking with someone who understands the risks of estrogen and your unique background, your unique risk factors, is really, really important when deciding whether or not to use it yourself. Now, progesterone, I just did an entire video on this for bone health. Progesterone has such a tremendous impact on bone health, but it also impacts other things too. Now, we think of it a lot of times just as the co-pilot for estrogen, right? Like it's there to protect the uterus and it doesn't do anything else. That's what a lot of doctors will say, even though we know in the literature that it obviously impacts bone health, it impacts vascular health, it impacts nerve health. I think progesterone can play a significant role in women across the board because there are progesterone receptors in probably every tissue, but in lots of tissues at a minimum. And it is there to balance estrogen for all of those tissues, not just the endometrium in the uterus. So I think progesterone is an underused tool, and I would recommend considering progesterone when you're walking down the pathway of what hormones do you want to replace in a postmenopausal state. Now, what about testosterone? Now, this is also controversial, so much controversy here. A lot of women are using testosterone and loving testosterone, but I use testosterone and I've seen some challenges with testosterone. There are a lot of women that have side effects, especially if they started older. We see issues with hair loss and hair growth on the face, et cetera. These are with relatively low doses. And so testosterone is a tool, but it's not necessary for all postmenopausal women. So unlike estrogen and progesterone, which drop off the map when you go through menopause, testosterone doesn't necessarily. 50 to 75% of testosterone production occurs outside of the ovaries. So it's possible that a woman only needs to work on adrenal health, potentially get some precursors like DHEA or pregnenolone, and then they could actually make adequate testosterone. And we see this happen in our practice, but it does take intentional effort. Testosterone replacement is an option, and again, we do it, but I like to think of testosterone replacement not as a single tool or a hammer whenever possible. If it's possible, we like to replace all three in conjunction with a comprehensive program. But we like to replace all three because all three are going to have unique impact on different tissues in the body in different ways. I like to consider the hormones to be working in symphony. And if you think about how they work in a premenopausal woman, they are fluctuating, they're up, they're down, they're doing this, they're impacting one. The presence of one provokes the presence of another. It is truly a symphony. As we age, as we go through menopause, maintaining as much of that as possible can be helpful, but there are a lot of different ways to do it. I don't like to pull one lever too hard. Again, that's the overdosing of testosterone thing that I see quite frequently. I will tell you this, that our experience is that there are a lot of different ways to do it. We need to consider what form a hormone is in. We need to consider what route, topical, oral, etc. We need to consider the dose. The lowest dose for the shortest period of time to relieve symptoms of menopause is not the answer from a HealthSpan perspective or a bone perspective. We also need to consider rhythm. Do we need to actually be pulsing some of these things? Do we need to cycle progesterone to get the best benefit? There are so many ways to do it, but most doctors are not trained in them, and ultimately they're just afraid to use hormones because of the research that came out in the early 2000s that has really tainted the current medical professionals, and this doesn't seem to be changing anytime soon. All right, so the top three things to consider for your bone health after menopause include the inputs. What are you eating? The outputs. What are you doing? And the inner workings. How are your hormones on the inside? Have you considered hormone replacement therapy to help offset the anticipated changes that occur after menopause? Now, if I could add a fourth, I would talk about cortisol and stress. I guess I'll have to make that a topic for another day. I only had room for my top 3 today. So if you are seriously considering hormones, and if you made it to the end of this video, clearly you probably are, then I would recommend going to our Hormone Masterclass. Our Hormone Masterclass is where we talk about a lot of the controversies in hormone replacement therapy. We talk about some of the nuance behind the risks, the potential benefits. We dig into some of the research and we answer questions. It's totally free. Link in the description below on YouTube, or if you're on a podcast, please go to PEMAbioidentical.com. That's PEMA bioidentical.com, and you can sign up for the masterclass there.